What are the practical steps that we can take to adapt our routine eye examination for our low vision patients? Well, it is important to have the appropriate charts available, especially when we're measuring acuities of less than 660. We know that electronic charts can measure VAs of up to 260, and handheld charts can measure VA to approximately 1/120. When assessing near VA, it's important to make a note of where the working distance is. It's also important to measure not only the smallest size print that the patient can see, but also the print that's actually comfortable for them to read. And this would be more indicative of what they can manage in their everyday life. You may also want to measure near VA on real-world tasks, for example newspapers, and also with and without a reading lamp. It's also standard practice in low vision to measure the near VA with a +4 add, as this corresponds to unit magnification and will be helpful when trying to work out what magnification is required. Historically, we know that visual acuity has been measured using the Snellen chart. However, within low vision, we tend to use logarithmic acuity charts, for example, the Bailey-Lovie or the EDTRS. And there are a number of reasons for this, but probably the most important reason is that they have more letters at the lower levels of acuity. So for example, between 660 and 624, there are 15 letters on the EDTRS. And if we compare this to the Snellen chart that would only have perhaps 2 letters, using the EDTRS or a logmar chart will enable us to have a more precise measurement of VA. And will also give some encouragement to a low vision patient who would otherwise only be able to read perhaps the top letter on a Snellen chart. In near VA, we're asking them to make sense of the letters and pronounce what they see as a recognized word, and this requires higher order cortical processing. The process is even more complicated as the task of reading not only involves having to pronounce the word, but altering your delivery in order to reflect meaning and context. And then the process of comprehending what has been read is also dependent on reading speed, which in turn is dependent on eye movement control. It's important to remember that the vast majority of our interaction with the world involves resolving low contrast detail. So it is important that we do measure contrast sensitivity, especially in patients where reported visual performance is less than the VA would suggest. It's also important in explaining to patients the impact of visual impairment. So here at Action, we use the Pelly-Robson, and this chart, when used at 1 meter, is designed to assess contrast sensitivity at the peak of the contrast sensitivity function curve and is best placed to correlate with activities of daily living where we know contrast sensitivity can be an issue. Refraction should always be performed as part of a low vision assessment, but the subjective routine may need to be modified. Using a ±1 cross-sill is often really useful, as is using larger steps when we check the spherical correction. It is important that we don't dwell on tasks that the person isn't able to do. For example, spending too long on a subjective refraction on an eye that perhaps only sees 260 is quite demoralizing for the patient, particularly if the other eye has a better VA. From a patient's perspective, it is important to make an appropriate choice of where to place the test chart initially. We know that visual field testing can be quite a challenge with people that have reduced vision, and therefore it is important to consider using a larger spot size on automated field instruments, or even using a coarser field assessment, for example confrontation or even a tangent screen.
Mm.